Okay, this is a short talk about identity, particularly about the identity of the chiropractic profession. Over the last few years, emerging research has started to uncover more around the sorts of elements that are being brought to bear in not only chiropractic clinical encounters, but in clinical encounters in general. And these are clearly complicated. Clearly, clinicians do deliver something. Chiropractors clearly deliver something. We know that they enter a room. We know that patients enter a room. We know that they talk with patients. We know they touch patients. Some of these things are self-evident in terms of what's going on, but a lot of other ones are not necessarily self-evident. Maybe unconscious, maybe body language, maybe subtle cues, maybe beliefs that are being signaled through, again, body language or tones of voice, and so on. And so it's not unusual to think that the therapeutic encounter itself is a complex phenomenon. And of course, we know that any human interaction can be complicated too. A cursory glance at a young couple, perhaps on their first date, talking at a dinner table, clearly illustrates to us that two people are talking and that they're of opposite genders. But we all know from personal experience and also from much research through human interactions and particularly primate interactions, that there's an awful lot else going on as well in terms of body language, body positioning, mirroring, eye contact, language, tone of voice, so on and so forth. And the therapeutic encounter is no less complex. So researchers have tried to understand which elements might be important, and some of them have attempted to categorize these into 5 broad areas. So probably one of the most well-known is the patient-clinician interaction, and of these, therapeutic alliance is something that most people have thought of. And clearly this is an important aspect of all clinical encounters, and no less in chiropractic encounters too. Things in therapeutic alliance include warmth, empathy, active listening, the ability to listen to the patient's story, the ability to form common goals with the patient, and a bunch of other multivariable aspects of therapeutic alliance. Beyond the interaction itself, which seems self-evidently important, we also know that clinician beliefs and characteristics can have important impacts as well. And so clinicians may have particular modalities they prefer, which they may signal to a patient through body language or tone of voice. We know that clinicians may have particular convictions around mechanisms which they feel are less or more important, particular modalities that are less or more important, particular commitments to those. Clinicians also can have particular paradigmatic beliefs, so they may feel that anything that is medical, however that may be defined, is something that they don't do, but they might do things that they might consider holistic and so on. And these types of beliefs and characteristics can impact outcomes. We know a lot about patient beliefs and characteristics also, which impacts outcomes. We know that, for example, aberrant beliefs about back pain, the idea that their back pain will never get better, that it's dangerous, that there is something that is broken, so on and so forth, have impacts on outcomes. And of course, clinicians can pile in here and make that worse. Treatment characteristics, we know that, for example, having surgery is a very powerful cue that something has happened. we might consider having an injection as something that is a type of treatment characteristic that comes with visual cues. It comes with medical cues if it's a medical injection. It comes with anticipation of pain. It comes with overt pain perhaps. It may come with bruising or soreness afterwards. There's something quite overt about some treatments compared to others. And lastly, and probably the least area, the least researched area, is clinical setting. And it is likely that for complex reasons, some types of clinical settings will have impact on outcomes more than others. And these may include colour, they may include airiness, they may include the presence of nature in some sort of way. We know, for example, that patients who have a view onto the outside tend to do better than those that don't have a view. And included in this could be music, sounds, odours, particularly if those have been associated with previous experiences that are good or bad. So any particular patient might have various proportions of these elements in a therapeutic encounter that are brought to bear, and for particular patients some of those will be more important than others. So we can see here there's various proportions of these 5 areas that might represent one patient, and we can see that for example the red hatched area, which may be, for example, patient-clinician interaction, would be much more important in order to maximize outcomes than it would be in patient 1. And so these things can be varied, and the variation might actually be important from individual patient to individual patient, which might explain why it's been so difficult to come up with robust generic predictors for who's going to get better and who doesn't, because we have these complex combinatorial elements that may be somewhat individual to individuals themselves. So what do we know about how neurology impacts physiology? Now, obviously, some of this stuff is straightforward. We know that, for example, if you're frightened, then you release adrenaline. We know that speeds your heart up, and you sweat. You sort of prepare for fight or flight, and it's not unusual for people to understand that. It's a relatively straightforward and early physiological mechanism that kids will learn in early school biology. However, it's now become likely, at least in terms of one of the most prominent theories, that the brain itself and how we perceive reality is more of a top-down type of phenomena than a bottom-up. So when I say top-down and bottom-up, one of the early classic theories around sensory information was that we understood the world and perceived the world by senses coming into our bodies and coming up into the brain, and the brain interpreting those senses and giving us a picture of reality, whether it be seeing a seascape or stepping on a stone. All of those senses came together to provide us with either a picture of the sea or a feeling of pain. However, it is increasingly likely that what we perceive as reality is actually dominated by predictions. So we have prior experiences that maps models of the world into our brains and generates a beforehand expectation of what should be happening based on initial sensory information. So we don't wait for all of the sensory information to come in and accumulate into an image. We predict early on in that sensory tsunami what is likely to be happening, and that becomes the reality. So in many ways we predict what our sensory information is conveying about reality. We do not necessarily wait for our sensory information to complete reality for us. So we have sensory information coming in, we have a model of the world in our heads based on prior experience. We have early sensory information coming in for a particular sensory experience, and we use the model to predict early on in that sensory tsunami, if you like, what is likely to be happening. And what the brain attempts to do, and this is where the Bayesian theory comes in, and why it's called the Bayesian brain, is to minimize the difference between what you think is happening and what your sensory information is telling you is happening. And clearly, you could have sensory information that dominates that image, or you could have your prediction based on prior experience that dominates that image. So there are two basic ways to minimize this gap. You can alter your prediction because the sensory data tells you that what you thought it was is not actually turning out to be what you think it is. Or more interestingly, you can alter the sensory data to fit the prediction. So if your prediction is very strong and you are very convinced that this is reality, then you modulate the sensory data in order to fit the prediction. So in that case, if your prediction is that you should be feeling a large amount of pain, you may feel a large amount of pain, sort of regardless of whether your sensory information is actually generating painful nociception. So the second of these two phenomena underlies the ability of the brain to top-down modulate sensory signals, such as pain, using multiple cues from the environment that inform a model of reality. So in terms of the model, this model is built on experience of multiple experiences through time and cues that are remembered as parts of those experiences will trigger models that predict what is likely to be happening. Now, in therapeutic encounters, these cues are a range of contextual factors that are categorized into the broad group shown in the previous slide. So in a therapeutic encounter, we generate multiple elements, many of which can alter the way that our brain modulates sensory data, particularly if the prediction is more dominant than the sensory data. So what are the mechanisms behind pain modulation? Well, they are complicated and they are more than just what I'm going to show you here. But we're going to have a look at one particular pathway. So pain perception itself is governed by a complex network of neuronal pathways that use a variety of neurotransmitters, some of which we know about, and I suspect some that will be yet to be discovered. But we know, for example, that anandamide, which is the neurotransmitter that mimics cannabis, noradrenaline, oxytocin, which is the sort of love neurotransmitter that's sort of become colloquially known as, and dopamine are all involved in some sort of way in some of the complex pathways that modulate pain, or modulate the sensory information that will be perceived as pain. But what we're going to talk about here and has an impact on what we're trying to talk about in terms of what is going on in a therapeutic encounter, particularly those where patients come with painful conditions, is a dominant pathway that includes two key neurotransmitters. So these are endorphin and cholecystokinin. And it now is known that the prefrontal cortex, which is the part of the brain which is centrally involved in understanding complicated social cues, the meaning of the world around us, and reward mechanisms, which are the sorts of things that drive us to do things, which are predominantly dominated by dopamine, are connected to descending pathways that reach to nuclei above the spinal cord, particularly the periaqueductal gray. And these pathways are dominated by endorphin receptors. Down in the periaqueductal gray, there are also receptors for cholecystokinin, and whether there are endorphin-dominated releases going on or cholecystokinin releases going on will determine whether your sensory signals are turned down, that would normally be interpreted as pain, or turned up, that would be interpreted as more pain. So you can sense or perceive more pain or less pain, almost disconnected from whether there is any damage. And we know that in situations where environmental cues are telling the cognitive model, which we're saying is going to dominate here, because it's going to modulate the sensory information coming in, that danger or threat is at hand, then CCK is dominant and released. And CCK is a neurotransmitter that is associated with anxiety and fear and so on, and it has a direct input on the modulation of pain in this pathway. In contrast, endorphin is released when environmental cues signal safety, comfort, and retreat from threat, and these can modulate pain downwards. And these endorphin receptors are also the receptors through which exogenous opioid drugs bind to and have the same effect. Interestingly enough, when people have become addicted to opioids, coming off opioids is so difficult because you down-modulate this pain regulatory system, which would normally keep the amount of pain that you feel from just normal sensory input from the body, for example, to levels where it wouldn't feel like pain. However, when this system is down-regulated through exogenous addiction, then when that exogenous opioid disappears, the system doesn't and cannot regulate the pain until after some time period. So we know now that because the perception of characteristics such as the clinician characteristics, patient characteristics, the patient-clinician interactions, clinical setting and treatment characteristics all are factors that can impact the cognitive side of the patient's brain, particularly the prefrontal cortex, which can then judge the meaning of the therapeutic encounter. And these areas of the brain are connected in downward pathways to direct modulation of pain. And so we can think of a pain dial as a simple way of looking at this, where endorphin release will turn pain down. So you might have a lot of nociceptive signals coming in, but you don't feel them because you've got endorphin release. Or you may have very few nociceptive signals coming on, perhaps none at all, and yet feel pain because you've got CCK release. So these two things are a sort of fear and safety axes. So environmental cues that can impact the release of endorphin and CCK are generated in various ways by these contextual factors present in the therapeutic encounter. So thus these powerful psychosocial signals, both negative and positive, elicited by aspects of the therapeutic encounter, directly modulate pain up and down. So those elements we looked at in the first slide can directly modulate pain. And of course, for clinicians, minimizing negative context, which can increase fear and alarm, feelings of non-safety, can have nociceptive influences on pain, and maximizing positive context are those that are going to turn pain down, are key skills in generating positive outcomes for MSK pain. So over on the left here are some examples of the sorts of unpacked categories of contextual factors which are present in all therapeutic encounters, including the chiropractic encounter. But over on the right here, I'm going to go through why this should perhaps make us think again around how historically we describe what chiropractors do. And the title says it all, really, that you're not just doing manipulation, even if you think you are. You're doing a whole bunch of things before you even touch the patient, as you walk through the door, even as the patient arrives at clinic, or even as before the patient arrives at clinic, if there's been expectations of good things likely to happen from the last time you saw them. So your therapeutic encounter actually, in some ways, sort of reaches out of your clinic to the patient in their home and their thinking and their future perception of the visit itself. So it's evident from a large amount of emerging research that manipulation is not the single underlying cause of clinical improvements in chiropractic patients. In contrast, it's likely, or highly likely, that contextual factors, as outlined here, are key causal elements in the improvements seen. So manipulation is not just the thing, it's not the only thing, and these other things are really important in directly impacting outcomes. Therefore, the chiropractic care cannot be characterized as a monotherapy dominated by manipulation, because manipulation is not the only thing that's going on, and the evidence so far suggests that manipulation is not necessarily the causal outcome or the causal factor that impacts the outcomes, the positive outcomes you see in practice. So we could simply go on describing the chiropractic therapeutic encounter and chiropractic care as really it's just about manipulation, which would be almost certainly wrong. Or we can begin to think and have conversations around how we articulate in a more truthful way and based on the evidence what is actually going on. And so what may be needed is a new evidence-based description of what chiropractors do. That includes an acknowledgement of the influence of powerful psychosocial cues in generating the positive outcomes seen in chiropractic patients. It's not a challenge unique to chiropractic profession, but questions historical descriptions used by other manual therapeutic approaches, such as osteopathy and physiotherapy, where physical modalities are used as core descriptors of the profession's skill set. And as we've seen up to now, these physical modalities may be just one, and sometimes in some patients, not really the dominant aspect of what is done to patients to cause positive outcomes to be seen. It also has implications for chiropractic education, where an explicit emphasis of skills inherent in modulating contextual factors, some of which are done, but perhaps other ones are not. Maybe we need some more research on that, but within the therapeutic encounter will need more prominence in chiropractic curricula. So, it may still be in some programs dominated by physical approaches, manipulation in particular, and perhaps we need to think about widening this curricula to include these other skills in more overt ways than we are doing at the moment. So, old me, new descriptions. So perhaps we're really looking at something like this and coming up with a set of words that perhaps more accurately describe what chiropractors do and what chiropractors is clearly, a difficult task. But these particular phrases here might generate further discussions. So one way of describing this could be along the following lines. So chiropractic care is best described as a package of skillfully delivered evidence-based therapeutic elements by specialist primary care clinicians. That's the truth, and that is what's going on. There are multiple elements, as we've seen. The therapeutic elements including clinical diagnostic expertise, hands-on modalities, specialized advice and education, and psychological support directly impact, as contextual factors, recovery and or better management by alleviation of pain, as we've seen, through top-down neurological mechanisms, which then can form the basis of a whole bunch of other more long-term changes, such as increased self-management, through trust of the clinician, perhaps where there's been barriers before, and a return to activity through the development of appropriate patient understanding of their painful condition, expectations and beliefs concerning MSK pain conditions. So in a way, these pain relief, which can come through the maximization of positive manipulation of these therapeutic contextual factors, can, as I said, form the basis of the beginning of a journey that the patient can go on, supported by the clinician, which will end in more long-term changes than just short-term pain relief, which is something that has been shown. And clinical emphasis on each of the 5 elements making up such a care package are varied in a patient-centered fashion, dependent on immediate patient presentations and needs and previous history and experience as informed by patient preferences, clinical judgment and evidence-based guidelines. Now, it's not quite as snappy as chiropractors manipulate, but with the evidence so far emerging, it's probably a more accurate description of what is going on. And to finish, this comes from a paper by a number of researchers, a part of OSullivans group, and a lot of you have heard of O'Sullivan and the whole rise of pain science. And this quote seemed to sort of, in many ways, exemplify perhaps some of the difficulty that we've had historically, and this it was predominantly focused at physiotherapists here rather than chiropractors, but it has messages to give to our profession too. And he says, we contend that the way that we have categorized interventions for low back pain into physical or psychological has created boundaries for what clinicians deem to be within their scope. In many ways, as we've talked about, the brain can be considered to be physical and biological, and so this false dichotomy between psychological and biological may be very unhelpful. He goes on to say, we now realize that interventions traditionally labeled as physical do not seem to exert their effects through purely physical changes in the musculoskeletal system. Instead, reductions in pain and disability after treatment, at least partially mediated by changes in non-physical parameters like self-efficacy, fear, beliefs, and distress. All physical interventions can be provided with a narrative. And the narrative we've really been talking about is that narrative, whether it be verbal narrative or whether it be a body language narrative or whether it be an expectation narrative, whether it be a confidence narrative. Those contextual factors we talked about can be provided with a narrative that exerts a positive, example, reduced fear and anxiety, or negative, increased fear and anxiety, influence on psychosocial factors. We know these psychosocial factors impact pain. And most importantly, psychosocial interventions involve meaningful interactions between the provider and the patient, and not just talking and listening. So words matter here as one example, but as we talked about, the therapeutic encounter, and one that a chiropractor delivers, at the very least has those key complex 5 areas which we as clinicians, or certainly as clinicians, the profession should be making sure that there is high skill in both recognizing when and with who and how to deliver those in a therapeutic encounter. Thank you very much.